Good morning.
Nice to have you here at the 11th Congress of Brain Behavior and Emotions in Porto Alegre, Rio Grande do Sul, Brazil. I would like you to introduce yourself, give your credentials for the
Okay. First, thank you for inviting me.
Okay.
So I'm Martin Bohus. I'm director at the Central Institute of Mental Health in Germany. I'm director of a large center grant on borderline personality disorder. And I'm focusing on borderline from scratch, which means from molecular genetics to clinics and treatment development since 25 years. So I dedicated my whole career on borderline. I'm a close friend and co-worker with Marshall Linehan. This means, on one hand, I'm doing a lot of neurobiological investigation of psychopathology and developing treatments and improving dialectic behavior therapy. So that's what I'm doing. And I have a clinic. We have about 30 beds, only borderlines, eating disorder, comorbid PTSD, co-occurring ADHD, and we have a huge ambulance, so we treat about 200 borderline patients per year. And this is a great source to do research.
You personally see patients?
Of course, I see patients. I'm running groups, I'm supervising, and I treat by myself.
Okay. I would like to know, in your opinion, nowadays, what would be the hot spot in your area of interest, borderline personality disorders, or in your area of research or clinical practice?
I would say you should discriminate between hotspots on development and needs. Since sometimes the hotspots don't fit the needs.
Okay.
Often the hotspots don't fit the needs.
Okay. And
So
what would be the needs? What would be the hotspots?
Okay. Let's say, what are the needs? The needs are, let's say, we are good now in helping them with emotion regulation. We are quite good in helping them to get control on dysfunctional behavior. We know how to help them to work through their traumatic experience. We are not good in our efforts and our success in social integration, and we are lousy in helping them to cope with their pervasive emotion of loneliness and being lost in space. And this means there's almost no research on this basic neuropsychological patterns of loneliness. And I think this should be one of the major focus in borderlines. So that's the one. The other thing is what happens currently.
Yes. You think it's the most important thing in
so what is happening now? I think we are in the midst of a paradigm change in psychotherapy, which means switching from individual-based psychotherapy to more computerized, digitalized training psychotherapy. And the issue is that we have a lot of good tools to really detect, fine-tune and detect neuropsychological problems. And we can use these neurobiological or psychological findings now to develop training tools. And the major issue is that psychotherapy is still in an old-fashioned, trapped in this old-fashioned that you think that explanation, thinking about, and that helps anything. The point is that psychotherapy is emotional learning, and emotional learning is at least as complicated as physical or motor learning, and motor physical learning needs repetition. And this means if you talk about how would you dance, you never learn it.
Yeah.
But if you train it, this means dancing, dancing, dancing. You get corrected and dance, dance, and then you learn it.
How would be an example of a tool that's being developed?
Let's say we've spent the last 3 years in working on the tiny little problems in social cognitions, and we found out, for example, that Polans have problems in processing positive social cues. So we developed training tools where they work on the computer to get, let's say, to work with positive emotions, to memorize them, to use positive icons on a gamified level. So they do memories, they do computer tools and so on. So they work every day an hour only with positive emotions to get used to and to lose their, to get used to it, to process it. So this means what comes is that they have to train at least an hour a day, and you have to develop tools who are that funny and that gamified that they do it.
And for how long?
This is what we have to test. So we are testing now simple doses response curves, like you do it in any other discipline. So also emotional learning is for sure a question of dose response, and nobody in the world has ever focused on that. So I think the next 10 years we will have, since it has been shown that computerized trainings are as nowadays, even when they are lousy and bad and not developed, and they are as good as individual therapy. There's no discrepancy.
And one thing, are those tools just for research, or there are some clinical?
No, of course. These are no. The point is that we have to use research tools for psychotherapy tools. Let's say we can. Let's say if you have trust games, you can do a lot of fine research tool in trust games, but now you can use the trust games to train patients to trust others.
So this is ready?
No, this is when the tools are ready to be tested. So we test it now under clinical conditions. So we do RCTs and we learn those response curves. So we develop gamified platforms where. The problem with computerized trainings is that it makes no fun usually, and you have dropout rates about 70%. So you need the personal relationship to a therapist to do this stuff. However, if you come up and you use tools which are usually applied in computer games, what we call gamifications, then you can make the thing much more fun. And this is what we're working on. And I think this will be a, let's say if you say a radical topic, you say, okay, within 10 years, I think computerized trainings will take over in psychotherapy.
If you could have a dream.
Doctor, excuse me, we want to